These are my disclosures. So this is a brief schema of how cabozantinib works. We all know it targets VEGF tyrosine kinase inhibitor. It targets VEGF tyrosine kinase, but in addition to that, it also targets some pathways which are known to be associated with resistant to VEGF TKIs, traditional ones such as MET and AXL pathways, which are also associated with growth, invasion, and metastasis. So this is obviously a very simplistic view of mechanism of action of cabozantinib. This was the trial which led to approval of cabozantinib, the METEOR trial, in which 655 patients who had progressed on 1 or 2 VEGF inhibitors were randomized to cabozantinib versus everolimus. These are the dosings. And treatment was continued until progression. No crossover was allowed. Primary endpoint was progression-free survival. Overall, the trial met the primary endpoint. Progression-free survival was met. 7.4 months with cabozantinib versus 3.9 months with everolimus. This is the longest progression-free survival we have seen with any monotherapy in salvage therapy setting till date. I want to bring your attention to the response rates. Obviously, response rates were better, more in line with nivolumab, 24% objective responses with cabo versus 4% with everolimus. However, I would like to bring your attention to primary progressive disease, which is basically means how many patients didn't respond at all. We all know that drop-off from first line to second line therapy and second to third line therapy in kidney cancer is almost 50%, based on multiple studies, most recently from IMDC study, almost 4,000 plus patients. Only 500 patients actually reached the fourth line setting. So it means there is a 50% drop-off from first line to second line, and that's why it is very important to choose therapies which have the least likelihood of primary progressive disease. So in this case, primary progressive disease was really remarkable. Only 12% patients didn't benefit, and which basically result in a very good disease control rates for cabozantinib overall. It also means more patients are going to see second or subsequent lines of therapies after treatment with cabozantinib. Overall survival in a subsequent analysis and update was met, almost 5 months improvement in overall survival with cabozantinib compared to everolimus. Second trial is Cabozant trial, which led to approval of cabozantinib in first line setting early this year. Again, it was a cooperative group study led by Tony Shori in Alliance. 157 patients who were treatment naive, belonged to intermediate and poor risk category, were randomized to cabozantinib versus sunitinib. And I just want to bring your attention that 40% of these patients had bone metastasis, as opposed to 20% patients who have bone metastasis in most of the clinical trials. Treatment was continued until disease progression. This is a snapshot of results of Cabozant trial. It met the primary endpoint of progression-free survival benefit of 8.6 months with cabozantinib versus 5.3 months with sunitinib. Also, we can see here on the right side, most of the subgroups actually benefited. Didn't matter whether MET status was positive or not, bone metastasis or not, and pretty much all risk group, stronger hazard ratio for poor risk category. Overall response rates are here with the last analysis. Again, the response rates, objective response rates, which were 34% versus 9% by investigator assessment, were found to be 20% versus 9% with cabozantinib versus sunitinib. However, again, would like to bring your attention to disease control rates, 75% disease control rate, which includes overall responses and stable disease. The median overall survival, obviously, trial was not powered with 157 patients to look for overall survival benefit. However, trends are still numerically favorable to cabozantinib. So these were the two studies which we all know have led to approval of cabozantinib in second-line or salvage therapy setting and first-line setting. So let's go to the trials which are ongoing. So there is a rationale for combination of cabozantinib with immune checkpoint inhibitors such as nivolumab, atezolizumab, and many other checkpoint inhibitors. So based on this picture, we can see here that cabozantinib does inhibit other pathways which led to increased number of circulating and tumor infiltrating cytotoxic T cells. These are not my data, I'm just reading off the slide. Promotes macrophage phenotype transition from M2 immunosuppressive macrophages to M1 macrophages. And also we know from VEGF-R2 inhibition, decreased number and function of regulatory T cells. And of course, AXL inhibition can increase the tumor MHC class 1 expression, which is also relevant in many tumor types. So this provides the rationale for combining cabozantinib with immune checkpoint inhibitors. So this is one of the trials which we are doing. Monty Paul is the PI. We are also involved quite heavily in this. Just the first cohort, renal cell carcinoma cohort, these are treatment-naive RCC patients who are going to be treated with cabo with atezo. This is a multiple cohort trial, and cohorts will be expanded depending upon what kind of benefits we are seeing. So large trial from the perspective of trial, but individual cohorts are smaller and which will be expanded as we see benefit. Second is, we all know about Checkmate 9ER trial. Initially it was cabozantinib with nivolumab versus cabozantinib with EP plus nivolumab versus sunitinib. The new two arms after amendment are cabozantinib with nivolumab versus sunitinib. Obviously, I think this is a better design because I was very hesitant to use ipilimumab with the original trial design. Primary endpoint is progression-free survival, and secondary endpoints are overall survival, response rates, and adverse events. And the last one, which I thought is really exciting, is combination of cabozantinib with CB839, which is glutaminase inhibitor. I'm involved in this trial with Nizar, Tanir, and Bernard Escudier. This is, so just a brief summary of what glutaminase is. A glutaminase inhibitor may do to these cancer cells. We all know that cancer cells are deprived of oxygen because of multiple reasons, and that's why glucose turns to pyruvate, but that goes on to become lactate and doesn't really make Krebs cycle very efficient. Cancer cells bypasses that by activating glutaminase here, which provides an alternative pathway to sustain the Krebs cycle and energy production inside the cancer cells by converting glutamine to glutamate, which basically feeds into the Krebs cycle. So glutaminase may be a valid target in these cells, in these cancers. So this trial with CB839, which is a glutaminase inhibitor, it is a large phase 2 trial, hopefully a registration trial, where almost 300 patients with prior 1 to 2 lines of systemic therapies, and we are encouraging nivolumab or any PD-1 checkpoint inhibitors and a VEGF TKI in first and second line therapy, and who have never received cabozantinib would be randomized to cabozantinib versus cabozantinib with CB839. And primary endpoint is progression-free survival. And there are several other secondary endpoints. With that, I think I complete my 9 minutes and 30 seconds.
So I got a question for you. The one trial, which is going to be Cabo plus Nivo versus sunitinib, how are you going to kind of interpret those results? If it's better, which you would expect at least it would be since Cabo already beat sunitinib, how are you going to kind of interpret it? Are you going to say, well, it looks more better, or what are you looking for in the endpoint of that phase 3 trial?
So which trial?
The Cabo plus Nivo versus sunitinib.
Oh, that is not my trial. That is basically a large phase 3 trial, I think led by Tony and somebody else, I forgot.
Yeah. But do you know what they're trying to look at? Because we already know Cabo's better. So instead of doing Cabo-Nivo versus Cabo, they put sunitinib. So you would assume the study's going to be positive, unless Nivo is a negative on it. So my question is, what would you kind of if it's a positive trial, how would you interpret that results?
So first of all, the trial will have hard time accruing in US because of sunitinib being the comparator arm. So I have concerns about that. And second is, so it will accrue in Europe or where first-line therapies like Nivo-EP or sunitinib or Cabozantinib are not available. I really don't know how to answer that question. I have concerns about I won't put patients on this trial. Yeah.
So talking about targeted therapy, we're really impressed by the PFS of Cabozantinib. How do you think about Cabozantinib versus lenvatinib plus everolimus? Which I thought, if you just talk about targeted therapy, is actually more impressive.
Yeah. So Cabozantinib as a single agent versus lenvatinib with everolimus, obviously toxicities are much bigger as in terms of patient burden compared to Cabozantinib. In my experience, Cabozantinib, we start with 60 milligram as we were discussing yesterday, but if you look at the Meteor trial, 40 milligram was the median dose for Cabozantinib. It is as well tolerated as sunitinib, although Nick Vogelsang would like to disagree with me, but I think it is as well tolerated as sunitinib at 40 milligram. So I think toxicity makes a big difference. I won't use lenvatinib with everolimus in a patient who is progressing on sunitinib, or even in first line. I would have a hard time using that combination because of toxicities. And of course, we always talk about cost. So 2 drugs versus 1 drug. I think Cabo beats the combination in both ways.
Great.
Okay.
Thank you very much.